started your timer and here is your question. Yes.
Yes.
Right. So if you have read and understood, considering it surgical pathology station, kindly tell me what are your provisional diagnosis for this patient?
Patient has a late peak murmur with
Very good.
S4 gallop, and patient my provisional diagnosis aortic stenosis. I also considered the myocardial ischemia.
Very good. Okay. One more you should tell me. How
For
would
this
you?
reason, we go.
Yes. In all right. Next time. Can you please tell me how would you confirm your diagnosis?
Okay. First of all, I do an ECG. Then I advise the patient for
Yes,
echocardiography.
ECG was already done. Yes. What would be your next step?
Yes, ma'am. And I do echocardiography.
Yes.
And X-ray test to see any cardiomegaly or secondary to failure. If echocardiography is conclusive, then I go for diagnosis. If not conclusive, then I go for angiogram.
All right. Okay. What would you see on echocardiography?
If aortic stenosis, then I see in echocardiography, I normally see the number of the valve size, function of the valve, and surface area of the valve, and jet flow or blood flow of the valve.
Yes. So if there is aortic stenosis, how would a patient present like on echocardiography? What would be your result? And how would you classify the results that you'll get?
We can finding the size of the heart valve, like normal heart valve in aortic aorta is like aortic valve is 2.5 to 3.5 centimeter square. If it is aortic stenosis and
Yes.
it causes a mild, moderate, severe.
Very good.
Mild is 1.5 to 2 centimeters square, and in moderate then is 1 to 1.5, and if it is become less than 1.5 centimeters square, it will be severe.
Very good. Considering the results, just suppose this patient has single S2, S4 gallop and carotid shudder. So how would you classify? And there is grade 3 to grade 6 crescent or descent or late. How would you classify patient's murmur and patient's condition of aortic stenosis?
Madam, just sign symptom. It will be moderate to severe.
Very good.
Patient already.
What are the management alternatives that you can offer to this patient?
If it is moderate to severe, then I advise to change of the aortic valve, like we have option like endoscopic valvoplasty, balloon valvoplasty, also metallic valve replacement, also tissue valve replacement.
All right. What since the patient is young, what are the types of aortic valve replacements that can be offered to the patient?
Mechanic valve is the best option.
Or the bovine one, because you want to help the patient sleep taking anticoagulants. Okay. If you go ahead and with the bovine valve and that does not succeed, and you end up reoperating on the patient, and this time you have opted for metallic valve. So what would be the dose of anticoagulant that you, and which anticoagulant would you suggest for the patient?
If we use a metallic bulb, then we advise the warfarin.
Yes.
For,
what would be the ideal dose to begin, and how would you begin the anticoagulant? Yes.
1 to 2 milligram per day.
Okay. How would you monitor the warfarin?
I monitor the warfarin level by APTT, and
yes.
also INR. You can see the INR condition of the patient regularly.
Okay. Can you please tell me, right, how much should be, or if a patient's INR or it's high, then how would you know what is the normal value of warfarin you should have?
Less than 1. Less than 1.4 maybe.
What would be the symptoms if patient is having warfarin's toxicity?
Madam, there is a chance of like a bleeding tendency like that. I don't know.
No.
Actually, sorry, ma'am.
Okay. Can you please? Okay, you should know, because where warfarin is metabolized, or how does it? What is the mode of action of warfarin? Then you'll know. Okay. Can you please tell me, why should you put the patient on warfarin? What can happen if you will not advise or add warfarin in the management of patient?
There may be again the development of calcification, and they again block the area, and aortic valve stenosis again develop to prevent a clot actually.
Yes, that is the most important. Yeah. Okay. Right. How would you assess the post-operative complications of this patient?
I will assay the repeated cardiac monitoring, repeated AC. I also see that culture sensitivity, there is any development of any infective endocarditis. I show also the symptom of infective endocarditis. And if I also give the patient a prophylactic antibiotic for 6 weeks, if there is chance of infective endocarditis.
What are the risk factors for aortic stenosis? How does it develop?
It occurs due to senile calcification, aortic stenosis, also post-inflammatory like rheumatoid heart disease, and also calcification of
patient is young,
congenital deformities.
Yes, very good. Because this patient is young, 48 is not that old. If it would have been 87 or something, then it would have been senile. But this patient could have been an underlying condition. How would you make sure that underlying condition is managed or under control? Otherwise, this replaced valve can also become useless in a while. So what are the underlying? Yes, please.
We consult with multidisciplinary team like cardiologist and also cardiosurgeon and we go do proper investigation and identify the underlying cause. Okay.
Right. I still have little time. You have answered very nicely, but there is one problem. When would you do, or how would you monitor APTT, and when would you do INR?
APTT for if we see the
if patient is taking heparin, then which anticoagulant test would you do? And if patient is on warfarin, then which one would you do? Okay, we'll come back to this one. Can you help me and read this ECG, please?
Madam, here, so the high voltage QRS complex in lead like B3, maybe.
V3,
blood,
yes. Yes.
Yes, yes.
The picture is not so good. I took it from here, but it's the
Yes.
picture of aortic stenosis very nicely.
It
Mm.
shows that left ventricular hypertrophy and deviation to the left side.
Yes, very
And
good. And what about the pattern in here? How would you describe that? And I also want you to comment on this one, this pattern. Lead.
yes, ma'am. Here is PQ in inversion. Sir, not clear, ma'am. Yeah,
No, it's not clear.
actually.
I'm sorry about that. But this was
No,
the
no.
best possible of aortic stenosis I could get. But there is this M pattern and there is this T wave inversion. If you could see.
Yes, ma'am. Yes, T wave inversion here.
It's there. All right, good. They will give you ECG to read in this one. So it's better you can. Okay, anyone else can, because you people are having exams, so anyone else will help and tell about APTT and INR.
Ma'am, if the patient is on the warfarin, we have to monitor INR.
Very good. Yes.
We want to keep the INR in 2 to 3 range.
Yes.
And if the INR is 4 critical value is 4.5, if it is
Yes.
more than 4.5, there is a risk of bleeding is there.
Yes.
And if there is a warfarin toxicity, we start the minimal dose like 1 to 2 milligram per day,
Yes.
and we titrate the INR. We try to maintain
Yes.
it 2 to 3. And if there is a warfarin toxicity, there is increased chances of bleeding from mucosal area,
Very
from
good.
GI tract and all. And antidote of the warfarin is prothrombin complex.
Very good. Yes.
Earlier, we
And
used to give trioprecipitate. Now we give
yeah,
prothrombin complex, consonant
correct.
complex, PCC.
Very good. Thank
And
you.
we need to involve the hematologist as per UP
Yes.
guidelines in
Yes.
the management.
Yes. Other than just the cardiac surgeon, he said. Cardiac surgeon, all right, you'll only involve when you have to do the valve replacement. All right, you'll follow up, but hematologist as well. Very good. Good. About heparin, because once you're operating,
If
you'll not start with warfarin right away. During
yes,
surgery, you'll give, yes.
yeah, if we are giving heparin or low molecular weight heparin, we need to monitor APTT. And
Yeah.
like if we are targeting extrinsic pathway, then we need to give monitor APTT or
APTT, yes.
yeah. If we are monitoring extrinsic pathway, which involve factor 7 and all, then we need to monitor INR because
All right,
warfarin
good.
inhibits factor 7. That's why we monitor by INR.
Good. One more thing. When would you decide to go for bovine heart valve replacement or metallic valve replacement?
Metallic valve have a ma'am do's that we in the metallic valve there is less chances of recurrence, but we have to
Yeah.
maintain the patient on long-term anticoagulation.
Yes.
In the bovine valves, there is a increased chances of dehiscence and all, but we don't need to keep the patient on anticoagulant. These are the advantages
Yeah,
and
that's the
disadvantages of these.
advantage. Yes. Plus, one more important factor is hands of the surgeon, skills of the surgeon. Sometimes skillful surgeon can even a skillful surgeon is the key. You know, if surgeon is not skillful, then even on the metallic valve, patient will have a valvular leak. So
Oh.
you'll again realize the patient is again having the symptoms, especially shortness of breath. So you'll realize and you'll do echo and you'll realize there's a valvular leak and it's not going ahead properly. So it depends on surgeon's hands and skills. Very good. Started your timer and here is your question. Right. So if you have read and understood, considering it history
Hello.
taking station, kindly begin.
I'm Dr. Bharat. Dr. Bharat, one of the surgical resident. May I confirm your name and age, please?
Hello, doctor. I am Kelly, 19-year-old.
Okay, Mr. Kelly, how can I help you today?
Doctor, I have a pain in my tummy for last 2 days.
Oh, I'm so sorry to hear that. Do you want to take some painkiller right now?
No, doctor. You can go ahead, doctor.
Okay, thank you so much. Can you please tell me where did the pain exactly started?
Yeah, doctor. It started in the middle of my tummy, doctor, and it is not going anywhere. It is staying there only, and it is coming. Sometime it comes, some it is like that, and it is
Okay.
associated. I had 2 episodes of loose stools also, doctor, in the last 2 days.
Okay. I'm so sorry to hear that. Can you please elaborate more about your tummy pain? Whether it was continuously increasing or it is having up and down pattern?
Doctor, as I told you, it sometimes comes, it sometimes goes.
Okay, I understood. It is anything that can relieves this tummy pain or anything that can increase this tummy pain?
No, doctor, I am not seeing any pattern like that. It is just coming in, coming out, just like that.
Okay, can you please elaborate me a bit regarding your tummy pain? That whether this is hindering your daily activities since past 2 days?
Yeah, doctor, I am not able to attend my school.
Oh, I'm so sorry to hear that. On a scale of 1 to 10, 1 being minimum and 10 being maximum, how would you like to grade your tummy pain?
Doctor, it was severe. I am I'm experiencing, I will give a score of 9 out of 10.
Oh, okay. I'm so sorry to hear that. Can you please tell me whether you had informed about the loose stools? How many episodes have you noticed these loose stools?
Doctor, I had 2 episodes in the past.
Okay. Since last 2 days, can you please tell me it was only 2 episodes or daily it was 2 episodes?
No, doctor, it's 2 episodes for last 2 days. It was
Okay.
just watery.
Okay. Have you noticed any slime or discharge separately along with this?
Yeah, doctor, it's some slimy layer over it, doctor.
Okay. Have you felt that your tummy pain is increasing after passing stools or it is decreasing?
No, doctor, I felt little bit better after passing stool, but I feel
Okay.
very nauseating.
Okay.
I was about to throw up.
Oh, I'm so sorry to hear that. Have you experienced this condition before?
No, doctor.
Okay. Have you been feeling any stressful life at the school?
No, doctor.
Okay. Can you please tell me whether you had any spicy food recently?
No, doctor.
Have you traveled anywhere?
Yeah, doctor, I recently visited to my aunt overseas.
Okay, I understood. Okay, can you please proceed further? If you don't mind, can I please let you know whether you have these episodes previously and visited any GP?
No, doctor, I don't routinely visited my GP.
Okay. Have you ever had any other surgical history to be mentioned?
No, doctor.
Okay. Can I ask you a few personal questions?
Yeah, sure, doctor.
Are you on any medications?
No, doctor, I'm
Okay. You are any non-allergic to any medication?
No, doctor, I'm not allergic to any medication.
Okay. Whom do you live with?
I live with my parents, doctor.
Okay. Sorry for asking you. Do you smoke or drink alcohol?
No, doctor, I don't take alcohol, don't take smoke.
Okay. What do you think that the cause would be?
I think, doctor, some infection is affecting my tummy, which leads to this.
Okay. So what your most concern is about?
I want to get rid of this, doctor. I'm concerned about why I am suffering from this.
Okay. What you're hoping us to do mainly?
I want to get rid of this, doctor. I want to get
Okay.
back to my life.
Okay. I'll discuss with my consultant and get the best possible thing done. I would like to ask you a few more questions. Is any members in your family also suffering from similar condition right now?
No, doctor.
Okay. Do you have any chest pain and difficulty in breathing?
No, doctor.
Okay. Do you have any difficulty in urination?
No, doctor.
Okay. Do you have any problem in your menstruation cycles?
No, doctor.
Okay. Okay. Thank you so much. I'll
Thank
discuss
you.
with my consultant and get back to you.
Okay, doctor. Thank you.
Okay, still at 20 seconds. Can you summarize your case now, please?
Tell me, a 19 years old female, Mr. X, came with complaint of abdominal pain, which has been there since 2 days and is associated with his colicky in nature and associated with the loose stools of 2 episodes with mucus discharge along with that, and also history of associated with history of nausea. So and positive history of being a traveling. And so my most probable diagnosis with given history would be it can be acute gastroenteritis.
Okay, and then 2, 3.
Or following that, it can be a inflammatory bowel disease, or it can be inflammatory bowel syndrome, or it can be a peptic ulcer disease.
Okay, how would you confirm your diagnosis?
Ma'am, I would like to confirm my diagnosis first giving the first routine blood investigation for looking for TLC, look for any infections, followed by I would like to check for the stool culture sensitivity, and also I would like to get a normal routine scanning of the abdomen to look for any lesions if present.
Okay, any what are the management options that you can offer this patient?
Ma'am, my first management option is, as patient is in pain, first and it is colicky pain, first I would like to give the painkiller to subside the pain, like antispasmodics. Following with that, as patient is feeling nauseating, I would like to give antiemetics and proton pump inhibitors to suppress the nausea feeling. And also, as she's having loose stools, I would like to give a natural biotics to control the loose stools. Then based upon my culture and sensitivity and the diagnosis, I would like to proceed further to add on antibiotics or not.
Okay. Any other?
And if patient is dehydrated, I would like to give her IV fluid administration. Yes.
Anything else you would want to suggest to the patient, considering it's gastroenteritis, your first diagnosis?
That's I will. Sorry, ma'am. As far as a concern, if it is a gastroenteritis, I'll give it for antibiotics if necessary.
According to your NHS program or?
Oh, sorry. According to the local trust guide policy.
Yes. Good. Okay. And here is your question. Right, so if you have read and understood, considering it clinical examination station, kindly begin.
I will enter the room. I will wash my hands. Hello, I'm Dr. Muhammad, one of the surgical doctors. They have been asked to examine your neck. Also, I would like to examine your hands and your eyes and your legs. Are you okay with that?
Yes.
Thank you. Can you have a seat in this chair, please?
Yes.
Can you please lower down your gown for me, please?
Okay.
May I confirm your name and age, please?
I'm Samantha, 62 years old.
Okay, thank you. I will take a look, general inspections. I will look for any if the patient is anxious or there's any respiratory compromise or the patient is agitated. Then I will take a local inspection at the neck. I will inspect for the surgical scars, for any dilated veins, for the site of the lump. It's overlying the anterior neck triangle. Also, I will inspect for the shape and the surface and the edge of the lump. Also, I will inspect for any visible pulsation. Can you stick out your tongue for me, please?
Yes,
Okay. Can you take a sip of water and put it in your mouth?
yes,
Can you swallow it right now?
yeah,
Okay, thank you. Then I will start feeling your neck from behind. Are you okay with that?
yes,
I will palpate for the tenderness, and also I will palpate for the temperature. I will compare with the rest of the body. Can you take another sip of water from me?
yes,
Can you swallow it right now?
yes,
I will palpate for the movement of the lump with the swallowing. Then I will palpate for the edge, and also I will palpate for any visible pulsations. Also, I will palpate for the if the lump is mobile or attached to the overlying skin. Can you tilt your head to the left side, please?
yes,
Meanwhile, I will palpate the left gland. I will push the right gland to the left side. I will do the vice versa. Can you tilt your head to the right side, please?
yes, continue please.
Okay. Meanwhile, I will palpate right gland and also I will push the left gland towards the right side.
And you'll feel it
Can you?
below the lump as well.
Yes, for any retrosternal extensions.
Yes,
Yes. Can you push your chin towards my hands, please? Looking for any attachment of the underlying structure, so muscles like sternocleidomastoid. Then I will palpate for the lymph nodes, the mental and submandibular, and also the deep and superficial cervical lymph node. Also, I will palpate for the periauricular and the post-auricular. Then I will palpate for the supraclavicular lymph node. Then I will do the percussions. I will
yes,
tap on your bone. Are you okay with that? We'll
yes,
do the
continue.
percussion of the sternum, looking for any sternal extensions. For that, I will palpate for the trachea to look for any tracheal deviations. And then I will listen to your neck. Are you okay with that? We'll auscultate for any pulsations.
Yes,
Okay. Then I will examine your eyes. Are you okay with that?
yes,
I will look for the top of head of the patient to see there any exophthalmos or any protrusion of the eyes. Then I would like to examine your hands. Are you okay with that?
yes, please continue.
Can you stretch out your hand for me and close your eyes? I'll put the paper on your hands, looking for any tremor. Okay. Then I will look inspection of the hand. I will look for any palmar femur or thyroid arcubaceae. Then I will palpate for the pulses, look for red Risman character. Then I would like to examine your legs. Are you okay with that?
Yes,
I will look for any breathable myxedema. Then I would like to do the reflexes, the knee reflexes. Can you expose your thigh for me, please? Then I will do the new reflex and I will look for the quadriceps muscles. Then after that, can you cross your arm over your chest, please?
yes,
And stand up. I'll look for any proximal myopathy. Thank you so much. Do you want me to
did you
help you?
examine the
with
eye
this?
for lead leg and Except
Yes, I
the
forget
thalamus.
about that.
Yeah.
Yes, after the examining the subthalamus, can you follow my finger from
Yes.
upside down? Look for the lead lag, and also can you follow my finger in H shape? Look for the eye movement or any lateral gaze.
Yes. In one H shape. All right.
Yes.
Okay.
Can you just now? Do you want me to help?
Right. Good. Very good. Belvin. Right. Can
Thank
you
you.
please summarize your examination? Thank you.
Yes, today I examined 2 years old female who presented with a neck swelling 3 months ago. On examination or general inspection, the patient is not anxious, not agitated, and there is no sign of respiratory compromise. On local inspection of the neck, there is anterior neck swelling about 5 by 4 centimeter, butterfly in shape. There is no surgical scars, no dilated vein, and no visible pulsations.
Good.
On palpations, it's not tender, and the temperature is normal in comparison to the rest of the body, and it's not attached to the underlying skin or underlying structure.
How
And
big
also
was the
it's
lump?
mobile,
Yes.
nodular inconsistency, and the edge is well defined, and there is no retrosternal extensions. After the
Size of the
on
lump?
yes, I said about
Okay.
5 by 4
Okay,
centimeter.
good. Yes. So what are your differential diagnosis for this patient?
My first differential diagnosis is multinodular goiter. Can be due also can be diffuse goiter and can also be due to lymph node enlargement.
Okay, so how would you manage this patient?
After history and taking triple assessment, history
Yes.
and examination, I will investigate for fine needle aspiration cytology.
Yes, and ultrasound. Yes.
Yes, and also I will do thoracic inlet for any retrosternal extension, and also I would like to do the ultrasound.
Yes. So what
And
are the
also I would
treatment
like to do thyroid
options?
function.
Yes. What are the treatment options that can be offered to this patient?
Yes, I will offer the total or near thyroidectomy.
Yes, after discussing in MDT.
Yes.
Yes, good. So that was
Thank
the
you.
most important. Thank you.
Yes, ma'am.
And here is your question. Right. So if you have read and understood, considering the surgical anatomy station, kindly please identify, yes, what is this organ that you're looking at, please?
Pardon, ma'am. The number F,
What is this organ that you're looking at?
it is hard, ma'am, interior.
Yes, very good. Can you identify the structures from A to H, please? What is A, please?
A is aortic arch.
B, please.
B is right auricle.
Sorry.
B is right auricle. B is
Yes.
right auricle.
C, please.
C is
Okay. D, please.
D is the tricuspid valve cusps.
E, please.
E is pulmonary trunk.
F, please.
F is left auricle.
G, please.
G is left anterior descending.
H, please.
H is papillary muscle,
Okay.
moderator band.
Can you please tell me how many surfaces heart has?
Heart has anterior, inferior,
And posterior as well?
posterior.
All right. Okay. Can you please tell me the relation of anterior surface of the heart?
It is related to the left lung and
Yes, you have to look that up as well. Can you please tell me the blood supply of the heart, please?
heart has basically two blood supplies on the right coronary and the left coronary.
Yes.
So the right coronary gives the right circumflex and posterior descending artery and right marginal artery, and left gives left circumflex, left inferior descending, and left marginal.
Can you please tell me the territory of supply of left coronary artery, please? Or
So
left circumflex coronary artery, yes.
Left supply basically the left atria, and then the most of the left ventricle, and left also supply the interventricular septum and a part of the right ventricle also, and it also supply AV node in 40% of the cases.
Right. Yes, in 90% cases, it's the right coronary artery which supplies the AV node. It was actually 40% SA node. You have little confusion.
60.
60 is right and 40 is left for SA node. All right. Can you please tell me what is the, since you have brought it up, what is the purpose of SA node? What is SA node?
SA node is the pacemaker of the heart.
Yes.
It generates impulses which travel to the AV node, and then the.
Can you please tell me what is coronary vein?
Coronary vein.
Yes, please. Where does it empty? Coronary vein?
It empties in the superior vena.
In the right atrium. But what is it? It's a bulk of venous drainage. Yes. What is coronary sinus?
Coronary sinus is the beginning of the right and the left coronary veins. The first branches of the aorta.
Okay. Can you please tell me the development of the heart? Okay. Right. Can you please identify the next image? Yes. In this image on the left hand side, there are certain circle structure. Can you identify number 9, please?
This is pulmonary trunk.
7, number 7, please.
Infundibulum.
1, please.
Tricuspid cusps, anterior cusp.
Are you sure? What is 5, please?
Papillary muscles.
Okay, what is 2, please? 2?
These are the papillary muscles also.
This is papillary
These
muscle.
are
How
50
many?
is the chordae tendineae.
Yes, these are the chordae tendineae. What? Yes. How many papillary muscles there are in the heart?
3.
Okay. What is the purpose of these papillary muscles?
They hold the this cusps to prevent them from any rupture.
What are chordae tendineae?
Chordae tendineae are the extension of the cusp to the papillary muscle.
Okay, right. If you can please come here on the right hand side image, and if you can identify this one, 12, please.
This is right marginal.
Okay, what is 1?
The great cardiac vein.
18, please.
It is the right atrium.
Moving on, if you can please identify, yes, these structures from kindly begin from 1, please.
This is
What kind of view is this? And what kind of image is this, if you can please explain?
it is from the inferior. I don't know.
All right. What is this V structure pointing at?
This is the cardiac vein
Okay, very
on
good.
the right side here.
What is this B from the back side, maybe? What is this? The red one.
No, ma'am.
Okay, 5, please, if you can identify.
This is the aortic arch.
Okay, moving on. Can you, okay, that was this last one. All right, what is C over here? C, D, and E, if you can identify.
These are the cardiac veins. I don't.
Okay. Right. How many, you said it supplies from right and left coronary arteries, but can you please tell me from where these coronary vessels arise?
From the aortic sinus, right and left aortic sinus.
Yes, the right
vein.
one arises from where and the left one arises from where?
Right from the right aortic sinus and left from the left aortic sinus.
Okay. Right, right. How many pulmonary valves, how many cusps does pulmonary valve have?
Three.
Okay. Right. At what level, if you can tell me, they are located?
They are at T6.
They said left second intercostal.
Second left side.
Parasternal edge. Yes, good.
Yeah.
Right, thank you. Right, so if you have read and understood, considering that you're still taking station, kindly begin.
Good evening. I'm Dr. Kuldeep, one of the surgical candidate. Today I have been asked to ask regarding your condition. Is it okay with you? May I confirm your name and age, please?
Okay. Please. Yeah,
Can I know
my
your
name
name
is.
and
Yeah, my name is. I don't want to talk to you, please. Who are you?
sir? I'm a surgical doctor here, sir. I am here to help you. Just let me know what is your name and age, please.
My name is Mr. X. I am 67-year-old.
Okay, nice to meet you, sir. Can you tell me how you feel today? What you bring to here, sir? Can you tell me, sir?
What brings you here? Yes.
What bring you here, sir?
I'm not feeling good.
Sir, for how long you are not feeling good, sir? Can you elaborate, please?
I'm
here to help
not
you,
feeling
sir.
good.
I know, sir. I am here. I am very extremely sorry. I am here to help you, sir. Just elaborate for me from how long you are feeling good. You are not feeling good, sir. Can you tell me, please?
Recently. I'm not
Okay.
sick.
Sir, you felt down, feeling down, depressed or hopeless, sir?
Yes, I've been happening this frequently nowadays since few months. Yeah.
I'm so sorry, sir. So have you been feeling like you are excessively tired?
Yes, sometimes.
Have you
Yes.
found that you are no longer interested in the activities which will provide you fun or enjoyment in earlier in your life?
Yeah.
Okay. Sir, can you tell me, is you finding any difficulty while going to sleep?
No, I don't have
Are you
anything
taking,
like that.
okay. Do you feel you have to wake up at night and you are not able to go back to your sleep again and again?
I don't know. Nothing like that.
Okay. Sir, can you tell me how is your food habits? How is your appetite these days? Is you taking your meal properly, or are you cutting down on your meals?
It's improper, not interested.
So can you tell me about how is your have you noticed any change in your libido, in your sexual drive?
No, nothing like that.
Sir, may I ask you some few more questions, if you don't mind?
Yeah.
Sir, have you, as I have seen in the record, sir, can you tell me why you was admitted earlier? This is your fourth visit to our hospital. What was the reason for the first to three visits in the hospital? Can you elaborate on that?
I don't know, doctor. I don't know.
Have you seen any therapist or have you attended any counseling session in the past?
Yeah. Sometimes I have attended some question counseling sessions.
Have you admitted for the same doctor?
No.
May I ask you some personal questions?
No.
Okay, doctor. Okay, sir. I will respect that. I will not ask that. Doctor, can you tell me, sir, do you take any over-the-counter medications?
Yeah, a few drugs I have took a mistake.
Okay, can you tell me, sir, which type of drugs you take?
My routine medication.
You visited your GP regularly?
Yeah, sometimes.
Are you suffering from any diabetes, asthma, hypertension, anything like that? Any long-term illness?
Nothing, doctor.
Okay. Sir, you live alone?
Yes.
Do you have kids?
No, we don't have any kids.
Okay. Do you smoke and take alcohol?
No.
Sir, do you feel any difficulty in breathing, having chest pain, any urinary tract, any burning sensation while you go for urination?
No, I don't feel anything like that.
Have you encountered any difficulty in climbing stairs?
Nothing like that.
Thank you, sir. I will try to help you. I will hand over these notes to my consultant and we will try to help you. Thank you.
Idea of concern.
Okay. Yes. Kuldeep bhai, thank you. But in a depression case, we are not supposed to ask anything, brother. As far as we have
Yes.
in your mind.
No, I tell
That's
you, but I tell you.
Yes. Wait, let me finish first. Okay, you have few minutes, few seconds left. Can you summarize your history now?
My patient is a 67-year-old male who came to the emergency for the fourth time with the altered with the state in the altered state in the confusional state. He is a known case of hypertension, diabetes, and hypercholesterolemia since 15 days, and he had take excessively dose of routine medication.
Yeah.
And
so that
on
was
examining
why, yeah.
on history taking, he had a biological and core symptoms of depression.
Okay, good. So how do you plan to manage this patient?
I will evaluate the patient. I will examine thoroughly, and I will discuss the patient in multidisciplinary board. And I will evaluate whether he had a mild symptoms or a moderate, mild
Very
or
good.
severe symptoms. If
Yes.
it's a mild symptom, I will start on her on regular exercises, advise of the sleep hygiene, and a psychosocial therapy. And
Yes.
if it is a moderate to severe, I will add along with a high intensity psychosocial intervention along with medication.
And if it's moderate to severe, then what
Then
else would you
I
suggest?
advise him to admit under a psychiatry ward using mental health act if necessary.
Yes, and medications, SSRI.
Yeah, I will start the patient on selective serotonin uptake inhibitor, reuptake inhibitor.
Okay. Yes, 40 seconds are still left. So, yeah. So what I was saying, what is Mental Health Act? If you can explain.
Mental health act is it's a act mainly leading to mainly giving the it's mainly deal with the rights and abilities of the patients who deal with the mental illnesses.
Which includes what? That you can forcefully admit a patient who is not
able to give a consent, or he is not able to understand
understand or is
whatsoever
not
treatment.
mentally stable. Yes. Okay, good. Thank you. Yes, for this one, I have chosen drug overdose and depression kind of this way. But in exam, you will have reactive depression, which will be post-operative. Patient was operated and sent home, and then patient comes back again. So yeah, so it was like it was once it was admitted, so you'll have the past record that patient was admitted, and then post-operatively depression can occur, cognitive changes occur once you operate on someone. So that's the kind of scenario. This is my scenario. Here is the question. Right, so if you have read and understood, considering it communication skills station, kindly begin.
Hi, I'm Dr. Mo, one of the subject analysts here. So
Hello.
may I confirm your name and age, please?
My name is Mr. X, 55 years old.
Mr. X?
Yes.
All right, Mr. X. So I've been asked to talk to you about about an investigation that we would like you to get. But before starting this, how far do you know about your condition?
Doctor, I have been told that there is some problem with me, and they told they'll plan a procedure. I am not sure about it.
Okay, so you don't exactly know why you need that. Is that right?
Yeah, please. I'm
All
not
right.
completely aware of it.
Okay. All right, Mr. X. So I'm going to explain to you what is going on inside your body. So so from the last investigation called barrier meal, and it indicated that there is a narrowing inside your food pipe. This is why you were having the symptoms. So are you with me so far?
Yes.
Yeah, to get the exact diagnosis, what is causing that kind of narrowing, we need to carry out another investigation called esophageal gastroduodenoscopy. In short, we can call it OGD. Yeah, it is very simple. There is a flexible tube, long flexible tube, which has the width of quite size. And at the end of the tube, we have a small camera attached. We will put that tube through your mouth, down to your windpipe, to your stomach, and then finally into the first part of your small bowel. So, are you with me till now?
Yes.
Okay. Yeah, and then that camera will transmit images to the TV so that we can see exactly what is inside your food pipe and what is causing the narrowing.
Okay.
And we can also take a tissue sample if we found anything abnormal and send it to the laboratory and get the diagnosis.
Okay. Is it painful?
No, Mr. X, we will put you under sedation, but it doesn't mean that you will be asleep. You will be away from the pain and you will feel a little bit drowsy.
Okay. So there won't be any risk involved.
Well, Mr. X, there isn't any investigation without any risks. There are few risks which include damage to your teeth, because we have to put the tube inside your mouth, and then you will feel your throat will be sore a little bit after the procedure. And you can also have bleeding from the side of tissue sample. Last but not least, the most serious complication is penetrating through your food pipe, but the chance is like 1 in 1,000. So it is not too common.
Oh, but I don't want to get under a procedure done under so many risks.
Yes, I understand that you are really afraid of that risks, but without getting this investigation done, we will not be able to get the final diagnosis and get you under the treatment.
But I don't want to get it done, doctor. I'm so scared about this.
Yeah, Mr.
So many risks are there. What can I do?
Yeah, there is another option called barium meal, barium swallow, barium meal, yeah, but it doesn't give enough diagnosis because we cannot get a tissue sample by doing that barium meal. Yeah, just only getting the tissue sample can provide us the perfect evidence and information to get how to treat your condition. Yeah, Mr. X. Yeah, this is why we want you to proceed this investigation.
Okay, why I keep on getting saliva? What's the problem with?
Pardon?
Why I keep on salivating, doctor?
Oh, right. Because if there is an obstruction inside your food pipe, it is altering the secretion from your mouth from going down to your stomach. This is why you have problem with your saliva from swallowing down. Yeah.
So you're telling me it is a cancer?
No, not. We can't exactly tell you if it is cancer because it's too early to say that. Only after getting the investigation result, we can tell you what exactly it is. Yeah.
Okay, so when will be the result will be coming? I'm waiting for it.
The result will be within 2 weeks' time. After the result, we will discuss with multidisciplinary team, and which include a lot of specialists, specialist oncologists, radiologists, and specialist nurses. Will take care of you.
Do I need to stay in the hospital?
No, Mr. Ace, you don't need to stay in hospital after that procedure because it is just a minor investigation. Yeah, we'll keep you sedation. If you there are actually two options before we start this procedure. If we give you sedation, you will be drowsy, so that you need to bring someone to accompany with you when you go back home, and you can drive for 24 hours. Yeah, another option is we give you a numbing drug to your throat, so that your throat will be numb. But if you go with that numbing drug, you can go back home exactly right after the procedure. Yeah.
Okay.
But there is one thing, you cannot drink anything too hot until the numbness has worn off. Yeah. Is there any question that you would like to ask me?
So now what do you suggest me? Is there, you have seen my investigation, is there anything abnormal more present? Is there anything other abnormality?
Oh, well, what we have just seen is that that you had barrier and swallow, and it shows narrowing inside your narrowing inside your food pipe. This is all we know right now. Yeah.
Okay, doctor, thank you.
Okay, Mr. Ice. Have a lovely day.
No, tell about the eating around the ODT time.
Okay, so before the procedure, you will, if the procedure is in the afternoon, in the morning, you have to avoid eating at midnight, starting from midnight. You can drink or eat anything after the midnight. But if your procedure is in the afternoon, you can have a light breakfast until 8 a.m. And you can also drink a small amount of water is allowed 2 hours before the procedure. Yeah.
And then summarize at the end to close.
So Mr. X, I have explained to you what we have found from the barrier meal, and I have explained all the why you need this esophageal gastroduodenoscopy, and also the risks that you can face with, and also the what to avoid after this investigation. So and the result will be within 2 weeks' time, and we will contact you once the result is back. So yeah. Yeah.
Yes, and if there is any question, then you can.
If you have any questions, yeah, you can feel free to contact me.
To the nurse, yes, you'll leave the number.
Thank you, thank you.
All right, good, thank you. Can you give feedback to Dr. Cynthia now?
No, ma'am, it was good. She covered everything properly.
Yes.
I think I don't know whether we have to ask or convey regarding two modes of sedation, or we are just keeping a standard mode like a mild sedation of 2 to 4 hours drowsiness post surgery, post procedure. Actually, or can we say about numbness or numbness in the sore throat?
Yes, this local anesthetic spray which is mentioned, and there is this other one. Yeah.
Okay, ma'am.
Anesthesia. So yeah, 2 are mentioned. So that's why. One, my suggestion or advice would be that once you begin your conversation, then you ask, all right, you have introduced yourself that I'm the exam candidate. Can I confirm how much you know already about the investigation for which you have been placed on list? So if you begin like this to make sure how much patient already has been informed by the consultant or how much patient knows already, then begin from there.
Okay.
Yeah, just
she do asked about that, ma'am. Yes.
She did?
Yes.
Okay.
Yeah,
yes.
Actually, I did ask how far do you know about your condition?
Okay, just
yeah,
or how much it has been explained. All right, good. Okay. Yeah, so how did you feel communicating with her? Starting the timer, and here is your question. Right. So if you have read and understood considering which surgical and orthodox patient, kindly tell me what area are you looking at?
Ma'am, I am looking at a cadaveric image exposing the neck.
All right. Okay. Can you please tell me in the neck there are certain triangles? How would you
Yes.
divide? Yes.
Triangles in the neck are divided into anterior and posterior.
Very
They are
good.
divided with the help of a muscle called sternocleidomastoid.
Yes.
And this anterior triangle is formed mainly in between by the midline joining the chin of the neck, chin of the mandible up to the sternum is in the central line, and laterally it is by the medial border of sternocleidomastoid, and superiorly by the body of the mandible.
Very
And
good.
and inferiorly it is a line, it's a combination of sternocleidomastoid with the center line. And posterior triangle is formed anteriorly by the posterior border of sternocleidomastoid and posteriorly by the trapezius.
Very good. Anterior triangle is further divided into anterior triangle is further divided into
Yes, ma'am.
how many triangles?
Anterior triangle is further divided into anti-triangle is further divided into submental triangle, submandibular triangle, carotid triangle, and muscular triangle. Mainly divided with the help of digastric muscle and omohyoid muscle.
Yes.
And superior belly of omohyoid along with the anterior and posterior belly of digastric divide these triangles.
Very good. What about the posterior triangle? What are the contents of the posterior triangle?
Yes, ma'am. So posterior triangle is nothing but the occipital triangle. Here, the inferior belly of omohyoid divides into occipital triangle and a supraclavicular triangle. In this, mainly the contents are external jugular vein and branches of ansa cervicalis. Those are lesser occipital, transcervical, and greater auricular, and external jugular vein and supraclavicular nerves and brachial plexus.
In the posterior triangle.
Yes, ma'am.
Okay.
And the brachial plexus.
Okay.
And the occipital group of lymph nodes.
Okay, can you please identify this organ 22, please?
Ma'am, it is a right lobe of thyroid, ma'am.
Thyroid, right?
Basically, it's a thyroid gland. Right and left lobe have been marked as 22.
What are the parts of the thyroid gland?
Thyroid gland is having mainly two lobes, right and left lobe. They are connected by a central isthmus.
Isthmus. Okay. What is the blood supply of the thyroid gland?
Thyroid gland is mainly supplied by superior thyroid artery and inferior thyroid artery. And superior thyroid is a branch of external carotid artery, and inferior thyroid artery is a branch of thyrocervical trunk, which is in turn a branch of subclavian artery. Likewise, there is third branch is called thyroid ima artery. It can arise from the arch of aorta, or it can arise from the brachiocephalic trunk.
Yes,
it's a less common
into,
artery.
Drains into what?
So there are three veins: superior thyroid vein, middle thyroid vein, inferior thyroid vein. Superior thyroid and middle thyroid veins they drain into the internal jugular vein, whereas inferior thyroid vein drain into the brachiocephalic vein.
All right. Okay. Can you please tell me what are the commonly injured nerves which one can come across during thyroidectomy?
Commonly injured nerves are most likely will be recurrent laryngeal nerve and external branch of superior laryngeal nerve.
Okay. Right. Can you please tell me what are the carcinomas of the thyroid which spread through lymphatics?
Ma'am, carcinoma of thyroid spreading through lymphatics is papillary carcinoma of thyroid and medullary carcinoma of the thyroid.
Very good. Okay, can you please tell me how many parathyroid glands are there?
There are mainly two types of parathyroid glands, total 4 in number. They are located on either side of the posterior aspect of thyroid gland. The superior and thyroid gland, they arise from the 4th branchial arch, whereas inferior parathyroid gland, they arise from the 3rd branchial arch.
Can you please tell me what type of secretions are secreted by these glands?
Secretions, parathyroid hormone secretes parathyroid gland secrete hormones called
Very
parathyroid
good.
hormone.
Which play a major role in
These are neuroendocrine
Calcium.
hormones. Basically, they'll get released into the blood circulation and
yes,
act.
they play a role in calcium.
They play a mainly role in the calcium homeostasis
Yes.
in the body.
Can you please tell me about the blood supply of the parathyroid gland?
Parathyroid glands are mainly supplied by an inferior thyroid artery. Yeah, both the glands are supplied mainly by the inferior thyroid artery.
Very good. Can you please tell me about the recurrent laryngeal nerve? The
Yes,
course
ma'am.
of the
Recurrent laryngeal now, there are two recurrent laryngeal now. There is a right side and a left side.
they supply which muscles?
Recurrent laryngeal now supply all muscles of the larynx except cricothyroid. Moreover,
very good.
yeah, and they
Unilateral
also
injury of this nerve can present as what, please?
Unilateral injury of recurrent laryngeal now presents as a difficulty in high pitch voice. So singing in high pitch voice will be sorry. I'm so sorry. No, I would like to correct it.
Yes.
I would like to correct it. Basically, unilateral will be presenting as a difficulty in abduction. So there will be breathing difficulty will be there along with
on
yes,
insertion.
Simeon effect in a partial injury, abductors are affected more than the adductors. So adductors are acting, so it will lead to phonation is betterful, but your respiratory is getting compromised. Whereas bilateral associated with breathing difficulty as well as aphonia.
Okay, good. Can you please tell me about the intracranial course of the facial nerve?
Yes, ma'am. Facial nerve arises from the two branches are there. Two areas. One is nervous intermediates, and other is the main part of the facial nerve. Arises from the pons. After arising from the pons, it traverses and it enters the internal acoustic meters, and it travels to the facial canal of the petrous part of temporal bone. After it comes out
how
to
many
stylomastoid foramen. It comes also stylomastoid foramen, and after coming out to stylomastoid foramen, it enters between the superficial and deep lobe of parotid gland, where it gives rise to 5 nerves mainly: zygomatic, temporal, zygomatic, marginal bandular, and cervical.
Good. Okay. Can you please tell me what type of facial nerve palsy occurs in acoustic neuroma?
In acoustic neuroma, in acoustic neuroma,
lower motor neuron
palsy will takes place. So both the upper side of the face and the lower side of the face both are involved.
All right. This mostly I've already asked you. Can you tell me about the strap muscles, please?
Strap muscles. Yes, there are two groups of strap muscles. There are superficial strap muscles and deep strap muscles. The superficial group, all of them are supplied by ansa cervicalis, except one that will be supplied by only C1. The superficial group will be sternum to hyoid, sternohyoid, and stenohyoid and thyrohyoid, and the deep group will be omohyoid and thyrohyoid.
All right, and their action is what?
A little
their action is depressing the hyoid bone for during the swallowing as well as for during respiration.
And larynx as well during swallowing.
Yes, larynx.
All right, good. Yes, Dr. HK wanted to add something.
No, the deep group and superficial group of the strap muscle, a little correction is needed there.
Yes.
Yeah, please.
Yeah, deep group is sternothyroid and thyrohyoid. Superficial group is omohyoid and sternohyoid.
Okay, hyoid muscles are superficial. All right,
good.
Which one is supplied only by C1?
Yeah, the thyrohyoid is the exception.
Yes.
Thyrohyoid alone. Okay.
Thyroid is innervated by C1. Good. Very good. Very impressive.